Imagine this scenario. You've been living with well, a kind of ticking time bomb in your chest. Your heart rhythm is chaotic.
All over the place.
Yeah, it's messy, skipping beats. You have atrial fibrillation or AFib. It's exhausting. And then there's this terrifying statistic hanging over you about stroke risk.
A very high risk.
So you decide to do something about it. You go in for a procedure, a big one, called catheter ablation.
Which is, I mean, it's no small thing. It's an invasive procedure to physically go in and correct the heart's electrical pathways.
Exactly. And the doctors go in, they, zap the areas causing the misfires, and it's a success. You wake up, your heart's beating in a perfect, steady rhythm again. The storm is over.
You feel like a new person.
You do. But then you go for your checkup, maybe a year later, feeling great, and the doctor hands you a prescription renewal for a heavy-duty, expensive blood thinner, and they tell you, you might be on this forever.
And that is the single most common frustration I hear from patients. They just look at you and say, wait a minute, you fixed the wiring, the arrhythmia is gone, so why am I still taking this heavy medication? Did the surgery work or not?
It feels like a total contradiction, doesn't it?
Mm-hmm.
If the mechanical fix worked, why do we still need the chemical shield?
It's a great question.
Well, today we're going to try and answer that question. We are looking at a brand new major clinical trial published in the New England Journal of Medicine on January 28, 2026.
This is a really significant piece of research. It's called the Post-Ablation Antithrombotic Selection Trial.
Let's simplify that.
Yeah, it's
Yeah.
basically a head-to-head showdown.
Yeah.
Two very different ways to prevent a stroke after a successful heart procedure.
So in the red corner, we have the heavyweight champion, rivaroxaban, a potent modern oral anticoagulant.
Mm.
And in the blue corner, the old veteran, the cheap stuff from the drugstore shelf, aspirin.
And the mission of this deep dive is to see if we can finally answer that patient's question. After a successful ablation, do you really need the heavy artillery of a drug like rivaroxaban? Or is simple aspirin actually enough to keep you safe?
Okay, let's unpack this. Before we get into the numbers, and there are some very surprising numbers here, we need to set the stage. We mentioned catheter ablation. For anyone who hasn't spent time in a cardiology ward, what are we actually talking about?
So think of atrial fibrillation as an electrical storm in the upper chambers of the heart.
Okay.
Your heart has its own internal pacemaker, but in AFib, you get these rogue signals that start firing randomly from the pulmonary veins. This makes the upper chambers, the atria, just quiver or fibrillate instead of pumping properly.
And that quivering is the problem.
That's the whole problem.
Yeah.
Because if the blood isn't being pumped out, it just sits there. It pools. And pooling blood, well, it likes to clot.
Right.
And if one of those clots breaks free, it can travel straight up to the brain. And that is the stroke risk.
So the ablation is like the firefighter entering the burning building.
That's a great analogy. An electrophysiologist threads a tiny catheter up through a vein in your leg, all the way into the heart. They use this advanced 3D mapping to find exactly where those rogue sparks are coming from.
And then what?
Then they use either radiofrequency heat or extreme cold to essentially burn or freeze that tiny spot of tissue.
They're building a fire break.
Exactly. They create a scar. And scar tissue doesn't conduct electricity, so it blocks the erratic signals from spreading. If it's successful, the heart goes back to a normal rhythm. The storm is over.
So, okay, if the storm is over, the blood is pumping normally. No pooling, no clots. Logic would suggest you wouldn't need blood thinners anymore.
Logic suggests that yes. But, medicine is rarely that simple, and doctors are professional warriors. The medical community has been terrified of what we call the recurrence gap. Meaning, just because the ablation was a success doesn't mean the risk is absolute zero. Maybe there are silent episodes of AFib that the patient doesn't even feel. Or maybe the atrium is still kind of stunned and prone to clotting. So for years, the default has been better safe than sorry. Keep them on the strong stuff.
But the strong stuff, anticoagulants like rivaroxaban, that's not just a vitamin. It comes with a price.
It comes with a significant price. These drugs are excellent at preventing clots, but they do that by interrupting the body's entire coagulation cascade.
Which means?
Means they also stop the body from clotting when it needs to. They increase the risk of bleeding nosebleeds that won't stop, GI bleeding, or even, bleeding in the brain.
And on the other hand, you've got aspirin, which we all see as much lighter.
It is. Aspirin's an antiplatelet. It makes platelets less sticky so they don't clump together as easily. It offers some protection, but historically, cardiologists have kind of viewed it as, well, wimpy compared to the potent anticoagulants.
So this study is really a risk-benefit analysis that affects thousands of people, balancing the fear of a stroke against the burden and risk of taking these drugs every day.
Precisely. And until now, we just didn't have a clear answer. The study's background explicitly says it. Whether successful catheter ablation eliminates the need for long-term oral anticoagulant therapy is unknown. That's the gap they're trying to fill.
So let's look at how they tried to fill it. Who were the people in this study? I'm guessing you can't just pick anyone.
No, and this is really important for you to understand. This wasn't just anyone with AFib. It was an international trial, 12,284 patients. But they had to meet very specific criteria. First, they all had a successful catheter ablation at least 1 year before the study started.
Okay, so these are people whose fix has held up for a year. They're not fresh out of the operating room.
Correct. The dust has settled. But they also weren't zero-risk patients. They used something called the CHA2DS2 VASC score.
I love these medical acronyms. It sounds like a secret password.
It's essentially, well, it's a scoreboard for stroke risk. You get points for age, high blood pressure, diabetes, things like that.
Yeah.
The patients in this study had a score of 1 or more, or 2 or more if they were female or had vascular disease.
So on paper, they still had risk factors for stroke, even without the arrhythmia.
Yes, exactly.
Got it. So we have over 1,000 people, successful procedure, but still have some underlying risk. How'd they divide them up?
It was a randomized open-label trial. They split the group basically down the middle. One group, about 641 patients, got rivaroxaban, 15 milligrams a day.
The heavyweight champion?
That's the one. And the other group, 643 patients, was assigned to take aspirin, somewhere between 70 and 120 milligrams a day.
And then they just waited for 3 years.
They followed them for 3 years, but here's where it gets really interesting. They didn't just wait for someone to call an ambulance.
No.
They did some serious detective work. They used magnetic resonance imaging MRIs of the head.
Wait, MRIs, why? Usually in these heart studies, they just count strokes. Why scan the brain if the patient feels fine?
Because they wanted to be absolutely thorough. They did an MRI at the beginning of the study and another one at the end of 3 years. They were looking for something called covert embolic stroke.
Covert stroke? That sounds terrifying. Like a silent assassin.
The very good description. A covert stroke is brain damage from a clot, an infarct, that happens without the patient necessarily knowing it.
So no face drooping, no slurred speech.
Not necessarily, but the damage is there on the scan.
So you could have a stroke and not even know it.
You could have a small lesion that doesn't cause immediate major symptoms, yes. But these silent strokes, they accumulate. Over time, they're linked to cognitive decline, memory loss, vascular dementia.
Wow. So they were counting the big, obvious strokes, but also checking under the hood for the silent damage. That sets a really high bar for success.
It really does. It makes the data so much more robust because you aren't just relying on symptoms. You're looking at the physical brain tissue.
Okay, I'm on the edge of my seat. We have the setup. Heavy hitter rivaroxaban versus the underdog aspirin. 3 years. High-tech brain scans. What happened? Did the strong drug win?
This is where we have to look very closely at the numbers because there's a trap here if you're not careful. The main thing they were measuring, the primary outcome, was a combination of stroke, systemic embolism, or a new covert stroke that was 15 millimeters or larger.
So a big clot, whether you felt it or not.
Correct. Now let's look at the raw count. In the rivaroxaban group, the group on the strong blood thinner, 5 patients had one of these events.
5. Okay. And the aspirin group.
In the aspirin group, 9 patients had an event.
Wait. 5 versus 9. That sounds like rivaroxaban did better. I mean, it's almost half the number of events. If I'm one of those 4 extra people, that feels significant.
It does look that way at first glance, doesn't it?
Mm-hmm.
The relative risk was 0.56. But, and this is a mass, but we have to talk about statistics, specifically the p-value.
The p-value, the gatekeeper of science. Break it down for us.
So the p-value for this comparison was 0.28. In medical statistics, you typically need a p-value of less than 0.05 to say a result is statistically significant.
And 0.28 is way higher than that.
Way higher. It means there's a reasonably high probability that this difference between 5 and 9 could have happened just by random chance.
So even though 5 is less than 9, science says not enough proof. It's like flipping a coin a few times. You might get more heads, but it doesn't mean the coin is rigged.
Precisely. The study could not prove that rivaroxaban was actually better. The confidence interval, which shows the range of where the true result might be, was very wide. It went from 0.19 all the way up to 1.65 Because that range crosses over 1.0, we just can't rule out that aspirin might even be equal or better.
That is fascinating. We just assume the stronger drug must be doing more, but statistically, it didn't separate itself from plain old aspirin. What about the smaller silent strokes, the ones less than 15 millimeter?
They look at those too. In the rivaroxaban group, 22 patients had these small lesions. In the aspirin group, it was 26 patients.
22 versus 26, that is even closer.
It's extremely close. The relative risk was 0.89. Again, virtually no significant difference. Whether you were on the potent anticoagulant or the aspirin, the rate of these tiny silent strokes was almost identical.
So if I'm hearing you right, on the efficacy side, preventing clots and strokes, the fancy, expensive, heavy-duty drug didn't statistically outperform aspirin in this specific group.
That is the takeaway from the efficacy side of the study. It really suggests that once the ablation fixes the rhythm, the clotting risk drops down to a level where the heavy artillery just isn't finding enough targets to make a difference.
If there's no enemy, you don't need a tank.
Exactly. But remember, every medication decision is a balance scale. We've looked at the benefit side, now we have to look at the risk side.
The bleeding. Because if they work about the same, the tiebreaker has to be safety.
Yes, the safety outcome. They looked for fatal or major bleeding.
Lay the numbers on us.
In the rivaroxaban group, 10 patients had a major bleed. That's 1.6%.
And aspirin.
Only 4 patients. 0.6%.
10 versus 4.
Now, again, the raw numbers are small. But when you run the stats, the hazard ratio is 2.51.
Whoa! 2.51.
Yes. That suggests the risk of a major bleed was more than double in the rivaroxaban group compared to the aspirin group.
So let me get this straight. The stronger drug, rivaroxaban, didn't significantly reduce strokes 5 versus 9, a statistical wash, but it did more than double the risk of a major bleed 10 versus 4.
That is the crux of the findings. You're paying a tax in bleeding risk for the rivaroxaban, but in this specific population, you are not getting a statistically significant dividend in stroke prevention.
That feels like a huge validation for all those patients who ask, why am I still taking this?
It certainly challenges the dogma. The author's formal conclusion was very carefully worded. They said that among patients with successful ablation more than a year ago and with risk factors, treatment with rivaroxaban did not result in a significantly lower incidence of stroke or embolism compared to aspirin.
It's interesting because usually medical trials are trying to prove a new drug is better. This one basically just showed the old drug held its ground.
And that is incredibly valuable information. In medicine, we often suffer from something called the risk treatment paradox. We treat everyone as if they're at maximum risk, just in case.
Right.
We're very good at escalating, adding meds, adding procedures. We are historically terrible at de-escalating. We're scared to take things away.
But this suggests that if the ablation is truly successful, if that mechanism is gone, the risk profile really changes.
It does. This study gives doctors the evidence they need to feel safe saying, you know what, you're doing well, let's downgrade you to aspirin.
So I want to circle back to the listener. Why should they care about this study? I mean, obviously, if you have AFib, this is huge. But even if you don't, what does this tell us about modern medicine?
It tells us that we have to constantly question our assumptions. For a long time, the assumption was AFib patients need anticoagulants, period.
Right.
Even after ablation, we were scared to stop.
Yeah.
This study provides the evidence to say, hey, maybe we can personalize this. It challenges that default assumption that stronger is always better.
It's a move toward precision medicine, isn't it? Instead of a blanket rule, we look at your specific situation. Did your ablation work?
Exactly. But, and I have to be the careful expert here for a second, we need to be very clear about the nuance.
Okay, hit me with the nuance. Who does this not apply to?
This does not apply to everyone with AFib. If you haven't had an ablation, or if your ablation failed and you're still having rhythm issues, this study is not for you.
You likely still need the strong stuff.
You absolutely still need the strong stuff. And also look at the risk scores. The patients here had moderate risk scores 1 or 2. If you have a really high score, say you've had a stroke before or you have severe heart failure, your doctor might still say, I'm not comfortable dropping your protection.
So don't throw away your pills based on our deep dive.
Please, yes. Talk to your doctor. But it is a conversation starter. If you fit this profile, you can now ask your cardiologist, hey, I saw this data about rivaroxaban versus aspirin post-ablation. Does this apply to me?
And that's what we want. We want you to be armed with the right questions.
There's another layer here I find fascinating going back to the MRIs. The fact that they looked for covert strokes. Even with aspirin, there were 26 small silent infarcts. With rivaroxaban, 22. That tells me that even with our best treatments, We are not at zero risk.
That is a sobering thought. Neither drug was a magic shield.
No. Biology's messy. We're trying to manage risk, not eliminate it. But if the protection levels are comparable, why accept the higher bleeding risk of the stronger drug? That's the logical conclusion.
It really flips the script. We think of aspirin as the wimpy option, but here it's the smart, efficient one.
That's the Goldilocks option. Just enough protection to manage the likely risk without introducing too much new danger from bleeding.
So what does this mean for the future? Will guidelines change?
Guidelines are like large oil tankers. They turn slowly. But a study like this in the New England Journal of Medicine is a powerful tugboat. It steers the ship. I think we will start to see more doctors comfortable de-escalating therapy.
Which is a huge quality of life improvement.
Absolutely. Less worry about bleeding and less financial burden. Aspirin is pennies compared to these newer anticoagulants.
That's a great point.
And it relieves the doctor of the fear of de-escalating. It provides scientific cover to do the sensible thing. I'm switching you to aspirin because the PAS trial showed it's just as effective and safer. That's a defensible position now.
PAS. Post-ablation antithrombotic selection. Not the catchiest acronym we've seen.
No, cardiologists are great at fixing hearts, terrible at naming trials.
We'll give them a pass if the science holds up.
Fair enough.
So, to recap, we wanted to know if we could downgrade from heavy meds after fixing the heart. The answer, based on this 2026 data, seems to be a cautious yes.
For the right patients, rivaroxaban did not beat aspirin at preventing strokes, but it did cause more bleeding.
It's a classic case of more isn't always better. Sometimes the mechanic fixing the engine means you don't need the super expensive additive in the fuel tank anymore.
That's a fantastic analogy. I might have to steal that one.
You can have it. Before we wrap up, I want to leave you with something to chew on. This study really highlights the relationship between mechanical fixes and chemical fixes.
It does. And here's a thought for you. We have spent the last 50 years of cardiology relying heavily on chemistry, on pharmacology, to manage these risks. Warfarin, then the newer drugs. We got better and better at messing with the blood's chemistry.
But this study seems to pivot back to the mechanical.
It does. It suggests that if the mechanical fix, the ablation, is good enough, the chemistry becomes secondary. For a long time, we treated the risks because we couldn't cure the defect, so we drugged the patient to keep them safe from their own heart.
Right.
But now, ablation technology is getting incredible. We're mapping these signals with pinpoint accuracy.
Yeah.
As the fix gets closer to a cure, the need for the chemical safety net diminishes.
Meaning we stop treating the symptoms and actually cure the defect.
Exactly. If the ablation works, this study suggests the body doesn't need that chemical override. It implies the body can return to a state of near-normal physiology. It moves the goalpost from symptom management to restoration of normalcy.
And if that's the case, are we entering an era where we can, I don't know, trust the body again?
I think we are. The body is resilient. If we remove the defect, that electrical storm, the body knows how to handle its own blood flow. It doesn't need us constantly overriding its clotting mechanisms.
It's a hopeful thought, moving from an era of managing chronic illness to an era of repair and release.
Repair and release. I like that. And for now, for the post-ablation patient, that release looks a lot like a simple daily aspirin.
Well, there you have it, a deep dive into the heart, the brain, and the medicine cabinet. We hope this cleared up some of the confusion.
Always a pleasure to explore the data.
Thanks for listening, everyone. Stay curious, ask good questions, and we'll see you on the next deep dive.
Goodbye.